Good morning to everybody. Welcome also if in the virtual setting in Verona. This is the big problem we have today. To be not here in person is really a great pity, and not to spend together time during the meeting and during the social time is really so sad for all us. Anyway, we have already started yesterday with a very nice, important session, and we'll try to take a look, keeping in mind the past, where are we going in the next decade for the radical approach to the pancreatic ductal cancer. So I think we will have a very nice occasion to improve our knowledges, to clear cut our mind for the next future, not only in the surgical treatment, but in the multimodality approach to pancreatic cancer. So Marcus, sorry for not being close to you. Sorry, because this night we are not going to drink together the Amarone wine in the Piazza Bra as we did the last time together. Anyway, thank you for coming, and thank you all for coming virtually in Verona. Please, Marcus, thank you.
Thank you, Claudio. Dear Matthias Löhr, dear Aldo, it's a great pleasure to lecture at the European Pancreatic Club. It's a great privilege to lecture about surgery in pancreatic cancer. I hope you can hear.
Very well.
Okay. As Claudio mentioned, I think the secret of success in science as well as in clinical management is coming together and putting our initiatives together. And then we can approach and we can go forward much better, as we have done in the 1990s. You see on this screen Claudio Bassi, our boss, but as well John Neoptolemus, Christos Dervenis, and myself. We founded the ISGPS and ESPAC, and only by these two groups we have really advanced our knowledge in pancreatic cancer. And I'm very grateful. And for the young surgeons and internists and research people, I would really encourage you to put your efforts together. You will jump much further than alone. Now, I will speak until 9:10 sharp, so I will stop at 9:10, whatever slide is on the screen, because surgeons are strict, as you know. And when it comes to surgery, then I have to remind you that surgery is the only chance for cure in pancreatic cancer. We should never forget this. We speak a lot about chemotherapy, immunotherapy, new approaches, whatever. But at the end, a good surgery can offer a cure. As you see on this screen here, you see for the first time of my talk, the triangle, which is the triangle in between the celiac trunk, the supramesenteric artery, and the supramesenteric vein. And this triangle needs to be free to prevent local recurrence. I'm coming back to this. The standard of care at this moment, when it comes to resectability, is surgery plus adjuvant therapy. And in the unresectable patients, the neoadjuvant treatment to make the patients resectable. Unfortunately, most of the patients can neither get surgery nor neoadjuvant treatment. Now, the question is always towards surgery, what is the achievement? What is the improvement? And maybe I can show you on this slide on the left side, Michelassi from Chicago, paper from 1989 showed that the 5-year survival after surgery was 5%. And then our good friend John Neoptolemus recently showed in our Lancet article that a 5-year survival after adequate surgery plus chemotherapy has grown to 30%. So there is a huge difference during the last 25 years. However, what counts is the type of surgery. My former co-worker, Oliver Strobel, who now is the chairman of surgery in Vienna, he published about 500 patients and the new R status. So the question of what is a good surgery? And a good surgery is a distance to the margin of 1 millimeter that should be tumor-free. If you achieve this, then in the pancreatic head cancers, you achieve a 40% 5-year survival. This is the blue curve, a real R0, a 40% 5-year survival, and a 40 months median survival. So please keep this in mind. What you can achieve is 40-40 in the pancreatic head cancers, and what you can achieve in the pancreatic left cancers is even more. If you have a 1 millimeter distance to the cancer, you achieve a 60-50, so a 50% 5-year survival and 60 months median survival if you do a real good surgery. This has also been shown by other groups. Look at the Verona group, where they published about 500 distal pancreatectomies, and they showed the very same, that the survival is something like 40 months as well as 40% 5-year survival after surgery. So surgery has become much better in the achievement, and it is important. However, you have to have a center of surgical treatment that has the surgeons, but also the gastroenterologists, the pathologists, the radiotherapists, and others. If you bring them together, your achievement regarding survival is so much better. We have a center in Heidelberg. Since I'm responsible there, we have done over 12,000 pancreatic operations, and we do some 60 to 80 per month. Most of what we do is pancreatic tumors and cancer, 80%. Most of what we do is resections. We have done 5,000 Whipples, as you can see, and 2,000 left resection. Total pancreatectomy is becoming more prominent. And it is a good operation for patients with advanced pancreatic cancers that sits in the middle of the pancreas, or also advanced main duct IPNM. The life quality has become much better after total pancreatectomy, thanks to our friends from gastroenterology and diabetology. Now, our overall mortality for resection of the pancreas is 2.9%, including training operations, including total pancreatectomy, including vascular surgery. It is 2.9%. Now, ladies and gentlemen, the best treatment for pancreatic cancer is prevention. The best treatment for pancreatic cancer is prevention. I say it again. Can we prevent pancreatic cancer? Yes, we can. In these kind of patients, we can prevent pancreatic cancer when we operate in time. We have recently published our IPNM data from Heidelberg in JAMA surgery. It is about 1,400 patients that underwent surgery. And we grouped these patients in too early surgery on the left side, adenoma type IPNM, in the right time of surgery, borderline as well as carcinoma in situ and too late for surgery when invasive cancer has developed. So it is interestingly in our population, it is 1/3 too early, 1/3 in time, and 1/3 of our patients we operated too late. So the big question is, who should we watch and wait, and who should we operate? Interestingly, in our too late group, 25% of the patients were in a watch and wait concept, which is certainly wrong when you watch and wait pancreatic cancer, because it is on the bottom of IPNM. And if we speak about mortality, and we are always discussing the mortality when we operate on IPNM, our mortality rate when we operate too early in IPNM is 1.6%. Our observational mortality, ladies and gentlemen, when we observe IPNM is 10%, when we only take the group of patients that were watched and waited longer than 1 year, and it is 25% when we take the whole 124 patients that were watched and waited for in Heidelberg in the cancer group. So we should bring it in the next decade to the point, what is the right time to operate on IPNM? The best cancer treatment is prevention. Now let me shortly speak about technical advances. Surgery of pancreatic cancer has improved so much by technical advances, and the Heidelberg group was particularly interested on vascular surgery, on the triangle operation. And I show you just very briefly some of the advances. On the right side, you see our artery first. So before we take it into our hand, the pancreatic cancer, before we cut the pancreas, before we do anything, we go down to the arteries. As you can see here, this is the left renal vein. This is the vena cava and the aorta. And here you see the supramesenteric artery, which we approach before we touch the pancreas. And then we also do uncinate process first, which is completely different to what we have done 25 years ago when we first cut the pancreas above the portal vein. Now we go first to the lower part of the duodenum. You see the duodenum is moved to the right side, and then we see the portal, supramesenteric vein and portal vein and supramesenteric artery, and then we travel from down to up to really do a radical surgery, and only later we cut the pancreas above the portal vein. As you can see here, the pancreas completely moved off the supramesenteric vein and artery, and only now we cut the pancreas above the portal vein. This makes it more radical. Now, if we speak about vascular surgery and pancreatic cancer surgery, ladies and gentlemen, this is part of the future. Why? Because we do neoadjuvant treatment more and more, and this makes patients resectable that have not been resectable. And for the resection, then we need to be able to do radical vascular surgery. As you can see here, the artery, the hepatic artery is replaced by a graft, as well as the portal vein is replaced by a graft, and the supramesenteric artery is divested. There is no more tissue on, and by that we achieve a radical surgery. So the young surgeons for the pancreas of the future should be trained as soon as possible in vascular techniques. This is just another example where the pancreatic cancer has grown into the vena cava, where we just take out the anterior part of the vena cava and replace by a patch. Now let's start with the portal vein. This is a portal vein infiltration in an advanced pancreatic cancer. Meanwhile, we have a classification for portal vein resection. This is a patch, this is end-to-end, and this is a prosthesis to replace, and we do this regularly. Fortunately, our French friends under Jacques Belgitti have developed a wonderful procedure. We can just take the peritoneum, the parietal peritoneum, to replace the veins, and we take a piece and then we produce a vein, and then we replace, as you can see, the portal vein just with peritoneum. A wonderful measure, as you can see here, peritoneal patch on the portal vein. I show you an end-to-end. The cancer is here, and then the portal vein is resected, and then the portal vein is re-anastomosed, which is daily during in Heidelberg. Once in a while, we have to re-anastomose the splenic vein to the portal vein, and we can also go with the splenic vein down to the renal vein, as you can see here. And we can also use a graft for the splenic vein down to the vena cava to reinforce the flow of the blood from the left side, and by that preserve the left pancreas for anastomosis. So the vascular techniques have increased our ability to do radical surgery. The problem is cavernous transformation. We recently published our data about that. What we do meanwhile is, before we resect the pancreas, we take a graft from the supramesenteric vein to the portal vein just under the liver, and then we have a decreased flow, and then we can easily do our resection without much bleeding. And then later we put the graft to, we make it shorter, but we can also put a graft in the beginning from the supramesenteric vein to the vena cava to decrease the blood pressure, and then later we put it to the portal vein when we have done the resection. So there are many techniques we have to learn and we have to achieve in pancreatic cancer surgery. Arterial resection, ladies and gentlemen, is demanding. I don't go into detail. I just show you some techniques. We use the splenic artery to replace the hepatic artery, as you can see here. We move the splenic artery to the liver side and put the splenic artery to the hepatic artery, or behind the portal vein, splenic artery to the hepatic artery, or we do an end-to-end of a right hepatic artery when it is infiltrated, together with an end-to-end of the supramesenteric vein. We can also do an end-to-end re-anastomosis of the supramesenteric artery. It works very well if you have achieved such techniques. We can also replace hepatic artery and supramesenteric vein with grafts. So the techniques are variable, and you should to apply them in the patients after neoadjuvant treatment. There are many more techniques. This is a vein, as you can see, to replace. This is another artery going on to the aorta and then replacing the hepatic arteries and then coming to the hepatic arteries with this graft. So there are many techniques. And they are not only done in Heidelberg, they are also done in Denver, Del Chiaro, 70 patients, or Mayo Clinic, 111 patients. So this is done worldwide. This is Mayo Clinic, as you can see. We have recently published about our 400 patients with arterial replacement and arterial divestments. I don't go into detail, ladies and gentlemen. Locally advanced pancreatic cancer, you know what we have to do. Neoadjuvant treatment, this is our data for neoadjuvant treatment, 600 patients. FOLFIRINOX works well in our hands. You see, this is the unresectable cancer, and this is after FOLFIRINOX. We take much advantage. 60% of our patients after FOLFIRINOX become resectable. The triangle operation is a very important operation. You see here, this is the triangle, celiac trunk, supramesenteric artery, and in between is the triangle that needs to be cleaned to avoid local recurrence. As you see, local recurrence is a big problem after non-radical surgery. This is 9 months after such a so-called normal Whipple. You see the local recurrence because the triangle was not cleaned by the surgeons. This is another patient after FOLFIRINOX where we do the triangle operation. You would not go for surgery here because you think it's not resectable, because on the other hand, after FOLFIRINOX, it is resectable, and then you do clean the triangle. Another patient here, 360-degree cancer around the vessels. You do the triangle operation, and then it is clean, and you achieve good data. I don't go into detail. Final message. I have 3 minutes, ladies and gentlemen. ESPAC. ESPAC is a very successful group that is created and led by surgeons. We have laid the basis for all kind of adjuvant treatment by ESPAC 1. You see, this is John as the first author, Claudio, Christos Dervenis, all the founders of ESPAC, myself, and this study was the fundamental study where we could show that adjuvant chemotherapy improves the survival. Our recent trial is the ESPAC 4 that has been published, and where we show that radical surgery together with adjuvant treatment, gemcitabine plus capecitabine, 40 months median survival, 40%, 5-year survival. This is what we have to achieve. 2 minutes more until I finish. Ladies and gentlemen, this is the best what we have ever seen. The so-called Brodich trial, adjuvant FOLFIRINOX, 50%, 5-year survival, 50 months, 5-year survival, if you apply FOLFIRINOX in the adjuvant treatment. This is so much better than all kind of neoadjuvant trials published. So the standard of care is radical surgery plus FOLFIRINOX in the adjuvant measure. Now, ladies and gentlemen, I'm coming to the end. 9:09, 1 minute more. This is the new building of the Heidelberg surgery that we opened in 2021. Whoever wants to come and see pancreatic surgery is cordially invited. We show you our daily 3 Whipples, where we do vascular or not, and you are most welcome to visit us. So Claudio, my friend, it is so good to do radical pancreatic surgery when it is possible from the patient side and from the surgical side. Certainly surgery alone is not the solution. We need either neoadjuvant or adjuvant treatment, but then we can achieve really good survival. Thanks for your attention.